very true statement that applicable not only to the first edition, but I believe to the rest of the editions. So let's start with the first poll question. And please answer in the chat box. So let's start with the changes and the 5th edition. The format of the 5th edition a bit different than the previous ones. It's organized in a sequence starting from from benign epithelial proliferation and precursors, followed by benign neoplasm, and then in situ, and then finally invasive breast carcinoma. The tumors that common to other system separated and grouped in a separate chapter, like mesenchymal tumor of the breast and hematolymphoid tumor of the breast. New chapters added tumors for male breast and genetic cancer syndrome. Also, each entity organized in a way very systemic approach with a number of subsections. The one in the red are the same subsections in the previous editions, and they added a new ones, a new subsection, the one in the blue. But the most, I believe, the cytology also added, but the one which I think it's really helpful for the pathologist, essential and desirable diagnostic criteria, which reinforce the key histopathological clue to reach the diagnosis, whether in a needle core biopsy or in an excision specimen. I just put here an example in mucinous carcinoma, but the same subsection can be seen in every tumor type. So let's start with the first change in the 5th edition. Microinvasive carcinoma. In the 4th edition, they mandated that the invasion should be present in the interlobular stroma. And we all know how difficult is that to distinct between the intralobular and the interlobular stroma, especially when you have high-grade DCIS with the, a large amount of fibrosis, periductal fibrosis and inflammation. So maybe maybe we already used to practice what's in the current definition in the current edition. We all used to apply my epithelial marker, and if it's lost, then maybe and fit the size fit, then microinvasive carcinoma. Then we call it microinvasive carcinoma. So the current definition, the invasion beyond basement membrane and myoepithelial layer less or equal to 1 millimeter. This is one of my recent cases. This is a duct with the DCIS, high-grade DCIS, and then you can see this cluster beside it. It looks to me microinvasion, but I applied a panel of 2 myoepithelial markers, P63 and the smooth muscle myosin, and in both you can see it's nicely lining the DCIS while it's negative around the microinvasive area. Medullary carcinoma entity has been recognized since the 1st edition in 1968, and it remains there until even the 4th edition, where even it is beefed up and called carcinoma with medullary features, and then we have 3 entities or subtype under this main heading. We have medullary carcinoma, a typical medullary carcinoma, and invasive carcinoma with medullary features. And maybe most of us experience when we have a case that we doubt which entity, and we sit with our colleagues around the multi-head, and then the amount maybe of inter-observer variability and disagreement to decide on which entity is that. So basically, to classify a case under one of these entities, we need to demonstrate all or some of the following criteria: circumscribed pushing borders, syncytial growth pattern, still with a high-grade nuclei, and then prominent lymphoid infiltrate. Interesting things that the prominent lymphoid infiltrate was not one of the criteria in the 1st edition. And then you will come to know that this criteria became the most important one, maybe in the next slide. So why and now the changes in the WHO 2019 that they eliminate medullary carcinoma as a distinct histological type and regard this as a histological pattern of invasive breast carcinoma of no special type. And why these changes happen? Because I just mentioned the poor inter-observer reproducibility of medullary carcinoma diagnosis, and that medullary features overlap with others like BRCA, carcinoma associated with the BRCA mutation, B-cell-like molecular phenotype, and some of the triple negative tumors. But I believe the most important reason may be the discovery of tumor infiltrating lymphocyte rich, which point to have a prognostic importance that explain the good prognosis, not behind what we used to call as medullary carcinoma, but good prognosis for all high-grade breast cancer with tumor infiltrating lymphocyte rich. So if you have a case with a high-grade tumor and then the stroma show predominance of lymphoid infiltrate, then you can use this terminology, invasive breast carcinoma of no special type with medullary pattern or tumor infiltrating lymphocyte rich. I'd rather using tumor infiltrating lymphocyte rich. Rare entities always have been there in WHO, like oncocytic, pleomorphic, lipid-rich, glycogen-rich, clear cell, and sebaceous carcinoma as a separate entity in 4th edition. But then they decided to, in the 5th edition, it's rare entity. There is no clinical implication of these rare entities. So again, decided to be one, again, morphological pattern of invasive breast carcinoma, no special type. So invasive breast carcinoma, no special type, basically it's a diagnosis of exclusion. Exclusion what? If you don't see a special histological variant like medullary carcinoma or mucinous carcinoma or micropapillary carcinoma or other special histological variant that we know that it will be by default an invasive breast carcinoma, no special type. So basically it's a waste basket. Initially, we used to call it infiltrating carcinoma in the 1st edition, but then changed to ductal carcinoma, NOS, through 2nd and 3rd edition. And maybe even until recently, most of us used invasive ductal carcinoma, and maybe still some people use it, invasive ductal carcinoma, NOS. And when I recently changed to invasive breast carcinoma, no special type, I used to get a phone calls from colleagues asking me where is the histological type. But then I told them this is exactly what we used to call it, invasive ductal carcinoma, NOS. Strangely, that this terminology has been changed in 4th edition to invasive carcinoma of no special type, but for some reason, still we will continue to use invasive ductal carcinoma, NOS. So the spectrum, the morphological pattern under invasive breast carcinoma NST really heterogeneous, and you can have a wide range of morphologies. I just mentioned the special entities that regarded as a morphological pattern and medullary carcinoma and even more. So a neuroendocrine neoplasm in the breast recognized as a separate, specific entity since the 3rd edition, 2003 WHO, and it remains there. And this, again, one of the entities that went through raise and fall in WHO. So in the 4th edition, it was under carcinoma with neuroendocrine features with 3 subtypes. Neuroendocrine tumor well differentiated, and then neuroendocrine carcinoma poorly differentiated, and then carcinoma with neuroendocrine differentiation. So what they decide to keep in the still the neuroendocrine neoplasm, it's a distinct entity in the 5th edition, but the subtypes underneath it, they decide to keep only, and this is exact terminology and the statement used in WHO, distinct and uniform enough neuroendocrine features and neuroendocrine markers expression. Now you will ask me, what does this mean? I mean, to me, this means that distinct and uniform enough, it should look like either what we call carcinoid tumor or atypical carcinoid tumor in other organ, or small cell carcinoma with diffuse neuroendocrine marker expression. And then what we used to call a carcinoma with neuroendocrine differentiation has been again moved as or considered as a morphological pattern under invasive breast carcinoma, no special type. So I will show you just one of the cases that came to our lab, that just an example of cases where we call a neuroendocrine neoplasm. This is a breast core. We can see it's bluish and with an area of necrosis on low power. On high power, if I showed you this case without telling you this is from the breast, you will know this is a small cell carcinoma. So this is type of cases that we call neuroendocrine carcinoma in the breast. And even on high power, you can appreciate all the morphological finding, overlapping, salt and pepper chromatin, mitotically active with area of necrosis. And when we do neuroendocrine markers, it was diffusely positive wall-to-wall for synaptophysin, chromogranin, and TTF1 also were positive. And we know that TTF1 can be positive in a small cell carcinoma regardless the primary location. This case was negative for ER/PR, and then the diagnosis was neuroendocrine carcinoma, fully differentiated, with the comment that correlation with the clinical and radiological to exclude metastasis from other primary. So what is the rationale behind this change? Why they moved neuroendocrine differentiation as a morphological pattern of invasive breast carcinoma, no special type? Because some neuroendocrine differentiation and marker expression noted in up to 30% of invasive breast carcinoma NST. And we know that some special breast carcinoma types like solid papillary carcinoma or hypercellular mucinous carcinoma, they will look like a neuroendocrine tumor, and they will express some neuroendocrine markers as well. And these entities are actually much more common to have than the real neuroendocrine neoplasm in the breast. So when to use this terminology, invasive breast carcinoma NST with neuroendocrine differentiation, and again, I will use the same statement and the WHO, that if neuroendocrine features and neuroendocrine markers not distinct and not uniform enough to classify tumor as a neuroendocrine neoplasm. Currently, no clinical relevance for neuroendocrine differentiation, and for sure, there is no recommendation for routine use neuroendocrine markers in breast tumors. And just of a note that breast neuroendocrine tumors by default considered as malignant tumors. Just I will show you a couple of examples on cases that we call invasive breast carcinoma, NST, in our lab. On H&E, you can see a nest of variable sizes. And by the way, most of the challenging cases between this and neuroendocrine tumor, it will be grade 1 and grade 2 invasive breast carcinoma. So this is like grade 2 invasive breast carcinoma, and then it has some uniformity, maybe some overlapping or could be crashing. We did sign up to it was positive. But on H&E, this does not look to us like a carcinoid or a typical carcinoid. So we decided in the lab that this is invasive breast carcinoma NST with neuroendocrine differentiation. I will show you another example as well. So again, nesting, maybe some uniformity, some overlapping, and then again, this is a grade 2 invasive tumor. We applied sign up to it was variably positive in this case. So again, we decide that this is invasive breast carcinoma NST with neuroendocrine differentiation. So we'll move to the changes in fibroepithelial tumors, specifically phylloides tumor. It's not uncommon to find area of well-differentiated liposarcoma or atypical adipocyte in phylloides tumor. And in the previous edition, finding such area was a criterion for malignancy. And you could upgrade the tumor based on these areas, but not anymore. So in fifth edition, finding area which look like well-differentiated liposarc or atypical adipocyte in isolation cannot be used as a criteria of malignancy in phyllodes tumor. So you need to find other histological finding, whether it's increased mitosis, infiltration, high-grade atypia to call it a malignant phyllodes tumor. And the reason behind this, because these areas of well-differentiated liposarc or atypical adipocyte in a benign, which looks like a benign phyllodes tumor, lack MDM2 aberration, and that we see in well-differentiated liposarc elsewhere, and the consensus that this area has no ability to metastasize. The other changes in fibroepithelial tumors, periductal stromal tumor, we know it was a separate entity in the fourth edition, but they decide in the fifth edition to make it as a variant of phyllodes tumor. Two new entities added in the recent edition. The first one, mucinous cyst adenocarcinoma. It's an invasive carcinoma. It will look exactly like what we see in ovarian and pancreaticobiliary cases. It's a cyst lined by tall columnar cell with abundant intracytoplasmic mucin and intracystic mucin. So it's a rare case, but in case you came across such case in the breast, just don't jump to label this as metastatic and think of primary ones. Now, in the literature or in the cases that has been reported, this entity in the breast positive for CK7, negative for CK20, and negative for CDX2. So it might help a bit to tilt toward primary breast if you are thinking of pancreaticobiliary cases, but then at the end, we know that we need to correlate with the clinical information and imaging to differentiate between a primary and metastasis. Other differential diagnosis in the breast from encapsulated papillary carcinoma, which we don't see mucin in encapsulated papillary carcinoma, not intracytoplasmic or intracystic. Other thing, applying ERPR will help to differentiate. It will be positive in encapsulated papillary carcinoma, while negative in mucinous cyst adenoma. A new entity added in the fifth edition, the tall cell carcinoma with reversed polarity, and this one categorized under salivary gland type tumors. This is very rare entity, and maybe up to 30 cases has been reported. And in the literature, you will find the terminology maybe solid papillary, but in the fifth edition, they decided to remove the word papillary and solid papillary from the terminology and just keep it tall cell carcinoma with reversed polarity. And the morphology basically the same as the terminology implies. You will have papillae lined with a tall cell, and then there is a reverse nuclear polarity, which means that the nuclei will face the opposite side of the core. It's usually triple negative, lack myoepithelial cells, and positive for high molecular weight cytokeratin CK5-6. Now, differential diagnosis would be solid papillary carcinoma, and we can use immunohistochemistry ERPR, which will be positive in solid papillary carcinoma and negative in tall cell carcinoma with reverse polarity. CK5-6 also will be positive in the new entity, while negative in solid papillary carcinoma. In one of Dr. Laura's virtual talk, she was talking about this new entity, and one of the cases was referred to her for consultation. And the referred pathologist did CK5-6, and it came to be diffusely positive. So he thought of usual ductal hyperplasia. So I thought it's a good to put it as a differential diagnosis in case some of you came across this and did CK5-6 by mistake. But usual ductal hyperplasia will be variably positive for ER, while in this entity, it's totally negative. Mixed invasive breast carcinoma, NSD, and the special type. In the previous edition, the cutoff point was 50% of a special type to call it a mixed. But in the 5th edition, now we have a wider range. We have from 10% to 90% to room to call it a mixed. And we have to record the percentage, the grade, and the breast predictive markers for both components in the report. Now, if you have the special type less than 10%, then still they give the option that you can mention that in the comment or in the microscopic description. Tumor infiltrating lymphocyte, I mentioned this when I was talking about one of the reasons why they eliminate medullary carcinoma as a specific entity in this WHO book. The importance of the tumor microenvironment, especially the mononuclear cells around the tumor cells, gain its importance long time when they talk about the multi-step carcinogenesis concept and the immunoediting theory. So there is a crosstalk between the tumor cells and the surrounding microenvironment. And we know that the host cell can get rid of precancerous cells and cancerous cells through immunosurveillance. But also we know that the cancer cell can acquire mechanism to escape from the immune response, or they even can acquire like a new alteration, new molecules that they can hide themselves from the immune system, or they can suppress the immune response. So now we know that the tumor infiltrating lymphocytes reflect a host immune response, and it's considered as a prognostic markers. Now, not only in the breast, but it's also in other solid tumors. And the higher the number of tumor infiltrating lymphocytes associated with better outcome and better response to neoadjuvant therapy, especially in, we are talking in triple negative and HER2 positive breast cancer. If we need to quantify the tumor infiltrating lymphocyte, we do it on H&E sections based on international consensus scoring recommendation. Now, in WHO book, there is a nice illustration how to do the scoring system, but also you can find very nice information and background in this website, TILS-breastcancer.org as one word. There is a nice background on tumor infiltrating lymphocyte, and they teach you how to do the scoring if you need to do that in an H&E section. Also, subtyping breast cancer based on ER and HER2 status into different biomarker-defined groups like ER positive, HER2 negative, ER positive, HER2 positive, and the rest of the subgrouping. Now, these subgrouping will have, it's a heterogeneous, they will have a big overlap when it comes to morphology and grading, but they have distinct response to therapy, distinct outcome, and distinct general genomic profiling. Now, talking about the genomic profiling and the molecular classification, and the early experiment in breast cancer was mainly to look for three things: either to find a prognostic gene or factor, or to find a molecule and gene that can predict a response to certain therapy, or find a novel therapy. So with all advancement in the technology and the rapid evolving our knowledge in genomics, this really helped to study the gene expression and through total set of RNA in a tissue. And this gene expression used to answer two main questions raised by our oncologist colleagues, especially for early breast cancer patients that should adjuvant treatment be prescribed, and which type of adjuvant treatment should be prescribed? Is it chemo or just hormonal therapy for early breast cancer? So studying the gene expression through certain set of genes that which are a surrogate marker for metastatic potential and aggressive biology will reflect the risk of recurrence. So if the risk of recurrence is high, then patient might benefit of chemotherapy. The set of gene that has been studied involved in a proliferation gene, invasion, HER2 genes, estrogen, and other cancer-related genes. So by looking into the level of expression and the pattern of expression, they could answer this. But also this helped to know the intrinsic molecular subtyping that all of us heard of it: luminal A, luminal B, HER2 enriched, and basal-like. They also went further, more steps to look into something we call it DNA copy number alteration, or basically this is the driver gene. So what is the driver gene behind breast cancer? They find that it could be loss of tumor suppressor gene or gain of variable oncogenes. So what they did, they combined the study of the molecular subtyping, intrinsic subtypings, with the driver gene. And they call this integrative cluster analysis stratification. So what this helped is, by integrating both study, they came up with more subtypes and more clusters. So for example, not all luminal A will have the same gene, driver gene. So under luminal A, there were 5 subclusters with the different and distinct genomic alteration. So going back to triple negative breast cancer, they studied a different set of genes that it's related to triple negative breast cancer, and they could identify 4 distinct subtypes: luminal, mesenchymal, basal-like immunosuppressant, and basal-like immunoactivated. So here, for example, in this cluster, basal-like immunoactivated, there is a room for immunotherapy for those patients. So at the end, the 5th edition, written by more than 150 most prominent in this field, and after 51 years from the first edition, which was in 1968, probably the best could be achieved at this point. And now I will leave the station for Dr. Dina to talk about the role of FNA in breast lesions. Dr. Roberto is consultant anatomic pathologist. He is have a big, wealth and knowledge in cytopathology and histopathology, and we are really happy to have him and to listen to his talk.
Thank you very much, Dr. Suhaila, and congratulations, very, very thorough lecture. I hope you can see the next slide, please, my first slide. The role of cytology actually in breast is rather different historically. It has basically evolved from being the first diagnostic test in pre-screening era to what is now basically a niche in the diagnosis of breast cancer. If we look at the, I think this is the second slide rather than the first one. But anyway, if we look at meta-analysis of the sensitivity and specificity of a needle aspiration cytology, we see that core needle biopsy is better than FNA as far as sensitivity, and it's also similar as far as specificity. Not only on the core biopsy, we can do many additional tests, including the standard ER-PGR HER2 tests as well, which are standardized and FDA approved on the core biopsies. And one of the reasons of the decrease in cytology was the fact that these methods were standardized and included in the guidelines for cancer screening of the breast. However, the authors of this paper, but also in general, it is agreed that the role of cytology is different between the countries where there's a population screening program as where there's just opportunistic presentation. Next slide, please. In fact, if we, thank you. If we look at the accuracy as well, besides the sensitivity and specificity on lesions which are visible on ultrasound, which is now basically the main tool which guides FNA, we see that again the inadequacy rate is lower for core biopsies as opposed to fine needle aspiration, and this is statistically significant. And this is particularly true in malignant lesions, while false negative are basically the same in the two groups. So besides the better performance of core biopsy for sensitivity and the more or less similar specificity, we have a lower rate of inadequacy. Next, please. And so basically, if we consider the paradigm and the main criteria for FNA breast lesion, we see that nowadays, predominantly in the countries with population screening, such as the UK, but actually most of Europe, we see that it is widely used to evaluate palpable lesions, especially in the younger age group, lesions which are not suspicious but are probably most likely fibroadenomatous in nature or fibroepithelial. But it's very much used for axillary lymph nodes, which is still the main indication for it. So it's used with a 23 and 25 gauge needle, and it can be done either with aspiration or without aspiration. Without aspiration was the preferred method, which was pioneered by the French school, Dr. Jacques Delat, at the Curie Institute in the 80s and 90s, because the yield of cells is still very good without aspiration in a cellular lesion, but most importantly, the blood staining decreases significantly compared with when we apply an aspiration. Certainly, the use of the larger syringe, the 20 ml syringe, has been discontinued because of this contraindication of contamination with blood. When the lesion or the breast is particularly fibrous, of course, you need to use a larger 22G needle. Next one, please. The technique is the same, that is, we tend to use ups and downs movement, whether we use aspiration or not. It's multidirectional, and the non-aspirative technique, as we said, are far less traumatic. Of course, in typical cases of fibroadenoma, the diagnosis is absolutely obvious. Interestingly, the combination of core biopsies and cytology is predominantly used in the private sector, where, I mean, there's not a cost issues related with this. Next one, please. So the classification of cytology is still based on the British breast screening program, already devised in 1993, which is still maintained. C1 is inadequate, which means that we don't have sufficient material to reach a conclusion, or otherwise there's contamination by blood, or simply it's completely a cystic lesion with no epithelial cells. Benign is the typical case of fibroadenomas, and in any case of representation of normal ductal and lobular cells. atypia probably benign is usually associated with lesions which are slightly more cellular and which may have some cytological or architectural atypia. There's no separation really between the two areas because in any case it's agreed that a C3 requires in any case a biopsy, an excision biopsy with final histology. C4 and C5 are grouped together basically, and the one is suspicious malignancy. Not all criteria of malignancy are present. C5 is when the criteria are actually there. And for the sake of sensitivity, they are actually grouped together. Next one, please. So these are the basic setup of cytology. But there are limitations. The complications are actually very rare, especially if you use a fine needle, and the accuracy of FNA is highly operator dependent. But it has some limitation. We already mentioned the false negative and the rate of inadequacy, but the diagnosis of some malignant tumors can be very difficult. It is well known that lobular carcinoma has the highest number of false negatives among FNAs, and it requires considerable experience. Next one. Lately, however, the cytology is growing very much, and this links very well with what Dr. Suhaila was saying about genetic molecular profiling of tumors. That is, FNA is ideally placed to monitor biological changes in metastatic breast, which may affect treatment and response. And while it might not be ethically approved to do core biopsies on all metastatic lesions, FNA is so minimally invasive and can provide very good DNA and RNA material. This has been shown by several groups because DNA and RNA preservation in cytological material is optimal in liquid-based cytology, but also can be retrieved DNA and RNA from smears as well. We know that tumor receptor conversion can be very frequent in as many as 10–16% of estrogen receptor positive tumors and about 10% of HER2. So there's increasing pressure towards documenting the immunophenotypic and genetic changes in tumors, metastatic breast tumors. So the European Society of Medical Oncology include in the breast cancer guidelines the recommendation now of resampling of tumor metastases. And cytology is the best way to achieve that. And that's why we are basically looking at implementing this methodology at NRL, where we have a molecular pathology lab with next generation sequencing, which is available from the next month or so. Next one. So basically the FNA is relatively painless from that point of view, but while some of the markers or biomarkers which are constantly used in breast cancer are basically standardized only on histology, we have to remember that good FNA material can produce excellent cell blocks on which we can reproduce the same methodology. And for HER2 assessment, only cytohybridization we know is valid for cytological material. But as these methodologies more and more commonly used, we will see certainly an increased use of molecular validation on cytological material. Next slide, please. This is just to recap the type of material that we can obtain from the different sites of metastatic spread in cytology, on which we can do molecular profiling as well. I think now we can run the query whether you might be interested or not in the future set of webinars to have a specific session, more diagnostic oriented rather than generic as this one, on breast cytology. We know from the previous webinars that there are topics on which you are interested and which we'll cover, and that is respiratory cytology and thyroid cytology. But if you show interest also, we can have a session on breast cytology. And I leave the platform to Dr. Suhaila to conclude.
Okay, thank you, Dr. Roberto. Thanks for the nice wrapping up the FNA role in breast pathology. So we'll move on to, I think I will leave the questions till the end, right? What do you think? Yeah, okay. So we'll continue with the third part, interesting breast pathology cases. So I wish if you can answer this case before we start with our case. Just please write in the chat box, what do you think is the most suitable answer for this? You can access the chat box by going on the top speech box, right? Speech box, yes. Okay. Just yes. Yeah, perfect. I believe all the audience are smart pathologists attending. Okay, so let's then move on with the case. This will really make the case easy and more interesting for you. So this is a 41-year-old female with a left breast lump, had needle core biopsy, initially called granulomatous mastitis, treated, unfortunately keep growing. After 6 months, she had lumpectomy, diagnosed as phyllodes tumor, but still keep growing with the clinically enlarged axillary lymph nodes. And then after 6 months, she had total mastectomy with axillary clearance. This was an outside consultation, so I received the slide and the blocks. And this was an extensive tumor involvement in all blocks. It was there, and all the way from the top, I mean the skin, the dermis, up to the deep margin, close to the even muscle. From this power, we can see there is a busy stroma here, with reaching up to the dermis and with the inflammatory infiltrate in between. So let us go higher on some of the areas. We can see this is residual duct, benign duct, no ATP, no DCIS, and it's surrounded by prominent lymphoplasmacytic infiltrate. In other, or going higher on the same area, you can see lymphoplasmacytic infiltrate, some fibrosis, and then scattered some large cells with prominent nucleoli. Also, we can see area with a central kind of necrosis and then surrounded by a mixed inflammatory infiltrate and histiocytes. So imagine if the needle core biopsy went through this area, I won't be surprised that someone will think of granulomatous mastitis. But then let us go and look for other areas where you see a fascicles of a spindle cell with the inflammatory infiltrate in between. And let us go higher on these spindle areas. Now you can see the amount of mitosis, like we have obvious, easily seen mitosis, and then atypia with the prominent nucleoli, and the background in some area mucinous, while in other area more kind of fibrotic looking. And then also looking into other area where you can see now that the tumor is still getting more epithelioid-like with a prominent cherry-like nucleoli and inflammation again scattered in between. So unfortunately, lymph nodes involved with the spindle cell, with the extracapsular extension. Now, the negative finding, there is no intraductal growth pattern or leaf-like pattern to suggest malignant phylloides tumor, no ductal carcinoma in situ, no classical invasive breast carcinoma, no heterologous component. Applying immunohistochemistry, I will start with the negative findings: GATA3 negative, CD31 negative, ER, PR, HER2 all negative, CD34 staining only the blood vessels. And of course, the savior here is the cytokeratin and basal marker P63 positive, and this is two different locations, by the way. We can see here on low power, more even diffuse. It's a focal, but it's a kind of a good and more than what we need to call this case what we need to call it. And here you have a positive, also focally positive, with the nice internal control of the residual entrapped duct. Cytokeratin cocktails positive also focally. So by now you know that we are dealing with the metaplastic carcinoma, spindle cell type, high grade. So since this case has been initially missed, let us look in the literature how frequent or rare to miss metaplastic carcinoma on needle core biopsy. Actually, it is not uncommon. And I find a couple of reports, by the way, both in radiology and pathology, this can be deceiving. So for example, this case, they thought epidermal cyst, and then after 9 months delay, they know that this is a metaplastic carcinoma. And both overcalling and undercalling has been reported, like this case, pleomorphic adenoma, which is misdiagnosed as metaplastic carcinoma initially. So what are the reasons behind false negative in metaplastic carcinoma? I believe heterogeneous characteristic noted in both imaging and pathology. And this also will account for sampling bias. So I just show you in the case that I present an area which might look like inflammatory mastitis. So this will add to more false negative. Also, there is a pattern, morphological spectrum and pattern in metaplastic carcinoma. We know we have a low-grade type and we have a high-grade type with a big list of differential diagnosis. And it's not uncommon for us to have a pathology slide without clinical information or radiological information, but always we have to go further step and to get more clinical information whenever we need to do that and contact our clinical colleagues. So it is important for all breast cases not to delay the diagnosis and reach the diagnosis from needle core biopsy. But the thing in metaplastic carcinoma, they are very aggressive tumor. They are chemo resistant, and maybe the response less than 10%, and they have a high risk to metastasize. So the priority should be given to initial surgery and a complete removal of the tumor initially. Now, the differential diagnosis in malignant spindle cell needle core carcinoma, number 1, 2, and 3 would be metaplastic carcinoma. So we have to first exclude metaplastic carcinoma, and then of course will be second in line malignant phylloides tumor, nodular fasciitis in some area that I showed you, which look more reactive. You might think of nodular fasciitis, but the primary carcinoma and metastatic carcinoma down in the list, we know all that it's very rare in the breast. Now, the approach, we will start with just morphological finding and H&E. We will look for area of DCIS, classical breast carcinoma, or epithelial differentiation, which will help to tilt the diagnosis toward metaplastic carcinoma. Or if we have a classical phylloides area, leaf-like pattern, periductal condensation, and intracanalicular growth pattern. And you know all that heterologous element can be seen in both phylloides and metaplastic, so it does not help to differentiate. A clinical history always important, and if this patient, for example, has a long history of old history of breast cancer, which has been treated with radiotherapy, and you have something which look like angiosarc, then you need to think of angiosarc. Immunohistochemistry and malignant spindle cell and metaplastic carcinoma especially is our best friend, and we have to be generous with the immunohistochemistry with the a different and a panel of keratin stains. So do whatever keratin you have in your lab. Do keratin cocktail, P63, CK56, 34, beta 812, and maybe you need to add CD34. But you need to know that keratin usually focal, so if it is negative keratin in needle core biopsy, it will not exclude metaplastic carcinoma. And to add more complexity to this, we now the focal keratin and P63 expression can be reported, and it's reported in malignant phyllodes tumor. So it's a difficult, if it's a challenging case, then don't commit yourself and just mention that this is a malignant spindle cell with a differential diagnosis. Discuss the case with your colleague, and I believe it's fine with them since they know it's malignant spindle cell. They have to assess the axillary lymph node anyway. So metaplastic carcinoma occur in up to 1% of all invasive breast carcinoma. Macroscopically, it can be well circumscribed, especially if it is high grade and with a high proliferation, or it can be irregular, indistinct, and low grade ones, cystic with central necrosis, especially if it is a squamous type. Axillary lymph node positivity up to 40% of cases, and then usually they are triple negative. A variable expression to different cytokeratin markers, and the most one usually positive that in the literature, P63 and CK and CD10 maybe. And this will tell you that some they think that the origin and histogenesis of metaplastic carcinoma is myoepithelial cell and not epithelial cell. The variant in the WHO, it is, we have a low-grade subtype and high-grade subtype. In low-grade subtype, we have low-grade adenosquamous carcinoma, and this entity, there is a glandular differentiation and a squamous differentiation in a bland spindle cell background. This, by the way, can look exactly like a syringomatous tumor of the nipple. By histology and by immunohistochemistry, and the only differentiating information will be the location. The other differential diagnosis for low-grade adenosquamous carcinoma, the cellular phase of radial scar, especially if you are looking into a needle core biopsy, the central part might look like this, but then the stroma will be more kind of sclerotic and densely collagenized. Also not much of squamous differentiation here, and just be careful when you do myoepithelial marker. The location of the myoepithelial marker here, it will be at the periphery of the duct, while here it will stain maybe the entire duct. It depends on the squamous differentiation. Other differential diagnosis will be tubular carcinoma, but then tubular carcinoma will be negative for high molecular weight like P63 or CK56, which will be positive here because of the squamous differentiation. Other type of low-grade metaplastic carcinoma, fibromatosis like metaplastic carcinoma, and in this entity we will have bland spindle cells with infiltrative borders. You might have some squamous differentiation, but very low atypia, low-grade atypia, and it might look exactly like it's fibromatosis, but then the immunohistochemistry will help a lot in this. Beta-catenin will be positive in fibromatosis, usually positive in fibromatosis, and cytokeratin panel will be negative in fibromatosis, while it's positive in fibromatosis like metaplastic carcinoma. The high-grade subtypes, I just present the spindle cell, but we can have squamous, we can have heterologous mesenchymal differentiation, and it can be monophasic or biphasic pattern. Mixed metaplastic carcinoma, I will talk about the mixed from this case. This is one of the recent cases. So we have at the top right side of the image, you can see there is a classical invasive carcinoma here. And then the lower side of the image, it's squamous differentiation or a squamous type of metaplastic carcinoma. You can see better on a higher view of the squamous part. So this is mixed metaplastic carcinoma and invasive breast carcinoma, NST. In the WHO, there is no percentage requirement to call this as a mixed metaplastic carcinoma. Because maybe of the importance and the implication of having a metaplastic component in an invasive breast carcinoma, NST. But I believe if it is very minor component and less than 10%, we need to mention that in the comment or in the description. So I believe we will stop here and we will open the floor for any question. I will read a couple of questions which came on. So I will answer. So I have to use different PC, sorry, to read the questions. So invasive breast carcinoma is that tell me indicate lobular as well. So there is a comment or there is a question. Sorry. Yeah. So one of the participants asking that using invasive breast carcinoma instead of ductal may indicate lobular as well. And I think the previous term invasive ductal more appropriate. So basically, they find that the histogenesis of this type of tumor, it is not ductal. That's why even I told you from the 4th edition, it has been changed, but for some reason, everybody keep using invasive ductal carcinoma, NOS. And for lobular, I believe if it is lobular, we have to be very clear to mention that this is a lobular. By the way, even lobular carcinoma is not initiated from the lobule. They don't know till now, but it's still the term, it's there. But if it is lobular, we have to mention that this is a lobular carcinoma. And you can still use invasive breast carcinoma, NST, and then put in a bracket that this is invasive ductal carcinoma, NOS, until everyone will be familiar with the new terminology. Okay, so please, I just want to remind you about the survey. Don't forget to fill up the survey. Thank you so much.